Today we focus on the plasma-derived chemical mediators of acute inflammation. Think of plasma as a toolbox already floating in the blood. When tissue is injured, four interlinked systems switch on and talk to each other. The Kinin system, the Clotting system, the fibrinolytic system, and the complement system. Each system has its own accelerators and brakes, built-in positive and negative feedback, so the response can start fast, but also shut down before it harms the host. Let me walk you through the map on this slide. An initiator in plasma turns on these cascades. The clotting system generates fibrin. The fibrinolytic system uses plasmin to cut that fibrin back down into fibrin split products. The Kinin system produces bradykinin, and the complement system produces C3a and C5a, which are powerful permeability and recruitment signals. Notice the crosstalk. Plasmin not only dissolves fibrin, its fragments and the complement peptides increase vascular leak. Bradykinin adds more vasodilation and pain. The big picture, these loops amplify each other to bring fluid and white cells to the problem quickly. The star of the Kinin system is bradykinin. Remember four effects. It contracts some smooth muscle, dilates blood vessels, increases vascular permeability, and causes pain. If you've ever felt the throbbing, tender edge of an acutely inflamed area, that's bradykinin doing its job early in the response. When clotting is activated, small peptides are released as fibrin forms. These fibrinopeptides are not just clot byproducts. They increase vascular permeability. They are chemotactic. They attract leukocytes. And they even have anticoagulant activity that helps keep the process from running away. So, the same pathway that stops bleeding also helps guide immune cells to the site. Next, the cleanup crew, plasmin. Plasmin has two key inflammatory actions. First, it can split complement component C3 to make C3a, a permeability-increasing mediator. Second, it degrades fibrin into fibrin split products, which themselves increase permeability and are chemotactic for leukocytes. So, breaking down a clot also boosts the local inflammatory signal. Complement can be turned on by the classical pathway or the alternative pathway, but either way it generates two important outputs: the anaphylatoxins, C3a, C4a, C5a, and the membrane attack complex, MAC. The anaphylatoxins make mast cells and basophils release histamine, which drives vasodilation and permeability. The MAC forms pores in microbial membranes to directly injure invaders. Here are the outcomes you should associate with complement. Increased vascular permeability leads to tissue edema, the swelling you can see and feel. C3b coats microbes and enhances phagocytosis. C5a is a potent chemoattractant for leukocytes, pulling them to the battle. And the MAC, that pore-forming complex, punches holes in microbial cell membranes to help kill them. Inflammation can damage the host if it runs too hot. The body uses several brakes. One set are acute-phase proteins, APPs, made by the liver as part of the acute phase response, often alongside fever and leukocytosis. Examples to remember: I1 antitrypsin, I1 acid glycoprotein, C-reactive protein, CRP, and serum amyloid A, SAA. They help neutralize enzymes, modulate inflammation, and opsonize microbes, turning a wildfire into a controlled burn. Other breaks include endogenous glucocorticoids, your own corticosteroids, which rise during infection and trauma to dampen the response. The body also releases free cytokine receptors that can soak up excess cytokines. Suppressor T cells, regulatory T cells, help tone down immune activity. And lipid mediators such as PGE2 and prostacyclin provide anti-inflammatory signals that counterbalance the pro-inflammatory push. Acute inflammation is not only local. Systemically, we see fever, driven by IL-1, TNF, and prostaglandins, plus leukocytosis and sometimes lymphadenitis or lymphangitis when draining nodes and channels react. In severe injury or sepsis, massive TNF release causes vasodilation and vascular leak, leading to intravascular volume loss, hypotension, and shock. If the coagulation pathway is switched on everywhere, microthrombi form throughout the body, causing disseminated intravascular coagulation, DIC, bleeding, and potentially death. This is why tight regulation matters. Finally, where does acute inflammation end up? There are four classic outcomes. Resolution. Everything returns to normal when the cause is removed and tissues regenerate. Healing by scarring. When damage is too great, fibrosis closes the wound. Progression to suppuration. Pus forms when neutrophils and bacteria dominate. Or progression to chronic inflammation, if the inciting agent persists or the response is dysregulated. Your job as a clinician is to read the context and predict which path is likely.